Good evening, everybody, and welcome to our next series of QA discussions with our professionals. So tonight we've got a really special guest for you with Mr. Ewan Griffiths coming to speak to us. And obviously, what's going to happen, he's going to have a discussion or do a presentation. Then we're going to go through the questions that everybody submitted, and thank you for all those that have submitted their questions prior to tonight, because obviously we can then group them together and organise it so it flows a little bit more. So without further ado, Mr. Griffiths, welcome. Thank you for giving up your time tonight. You know, we really do appreciate everybody who does this for us, because we know how valuable all your time is. So I'm going to hand it over to you.
No, thank you, Duncan, and thank you for the TOS team for inviting me. I remember coming to the group meeting near Warrington about 4 years ago, face to face, and then, of course, COVID kicked off, and it is a pleasure to speak to you. Bit of a declaration: I'm an adult surgeon. I mainly treat upper GI cancer and benign disease, achalasia, hiatus hernias, and the like. I've done no specialist pediatric training. I'm very much a surgeon, not a gastroenterologist. I mean, the disease we're talking about here today is very rare at the best of times, but dealing with the consequences of the disease in adults is a limited part of my surgical practice. So it's very, very interesting. And I do try and help patients that get referred to me as best I can. And I'm hoping the stuff I'm going to talk to you about is helpful. When I got contacted, there was quite a number of questions about reflux disease, about upper GI endoscopy, about Barrett's esophagus, and also fundoplication. So I thought I would split my talk into these 4 groups, and perhaps I could just give a bit of the talk, and then we can pause, and any of the questions I didn't fully answer, we can discuss. So I hope that's okay. Starting off with reflux disease, gastroesophageal reflux disease. Well, what is reflux disease? Well, it's a constellation of symptoms due to acid or bile coming up the esophagus. It's very common. It's very common in patients with surgery for esophageal atresia and TOF surgery. And I'll explain the reasons for that. I'll explain a bit about what investigations patients might go through and what can be done non-surgically about reflux, and talk a bit about PPIs and alternatives to PPIs. So these are all the things that protect the esophagus getting acid in it from the stomach. One of the main things is the lower esophageal sphincter. This is a muscle that normally is closed and only relaxes when food passes through. So that's one of the main mechanisms to stop acid coming back up into the esophagus. As well as that, the diaphragm, the muscle of the diaphragm provides muscle fibers and a tight, fairly tight height or ring. And that's a key factor in preventing acid reflux as well. And a part of the esophagus, a small part, is intra-abdominal. And if you go back to your basic physiology, the way we breathe is by producing negative interthoracic pressure. So esophagus and the abdomen helps that pressure gradient keep stuff in the abdomen rather than the esophagus. And those top 3 things all fall to pieces when a hiatus hernia appears, because the lower esophageal sphincter muscle loses its pressure, the diaphragm muscle becomes weakened, and the esophagus springs up into the chest, and all these things contribute to acid reflux. Another key factor is the motility of the esophagus, and what I mean by that is the way it contracts and moves. In normal patients, when you swallow, the food bolus hits the back of your throat, and there's a very coordinated contractive mechanism which pushes that food down in a coordinated manner and then opens up the lower esophageal sphincter at the bottom. Other factors are this angle of Hess, which I don't know if you can see my pointer, but it's basically the angle where the top of the stomach and the esophagus meets. And if that's a high angle, that prevents against reflux. And the other thing is gastric emptying. So if gastric emptying is impaired or reduced, patients could be more prone to reflux. And sadly, all these factors are dealt a bad blow by having surgery or treatment for esophageal atresia or tracheoesophageal fistula as children. And there's various mechanisms for this. The actual surgery itself may damage vagal nerves. It may induce a hiatus hernia. It certainly affects the motility anyway because of the way the esophagus develops properly is by developing a neuronal network which will do that coordinated effort to push the food down. And all these factors are a factor that will predispose patients with TOF, atresia to reflux disease. And this is what we can see at an endoscopy, looking down endoscopically. And this is a grading system of gastroesophageal reflux disease, which is commonly used in adults. And you can see in this grade A, there's just a tiny little fleck of a slight singe. Grade B is where there's much more of a singe of acid going up, an erosion. And grade C where it's quite pronounced, and grade D is where it's worst. It can be. It's effectively a burn of the esophagus, and that's what we see endoscopically when we look down in patients with reflux disease. And hiatus hernias are a common cause of reflux, and may indeed can be caused by the surgery for TOF. And in adults, they're graded into different types depending on how big they are, what the anatomy is, whether the esophagus is in the right place or not, or whether there is loads of type 4s where there's loads of stomach in the chest and also other organs such as colon and other features, so they can be graded that way. Patients, as well as having endoscopy, may have a barium swallow. And this is a picture of a hiatus hernia. It's a specific type of hiatus hernia called a paraesophageal hernia. And in this patient, they may complain of dysphagia as the stomach actually compresses the esophagus to the side. And this is after I've fixed the hiatus hernia. And this is in a standard patient without a TOF or an atresia surgery. But when we're assessing patients for suitability for surgery, one of the key investigations is manometry, and this is a test where a pressure probe is placed in the esophagus through the nose down into the stomach, and there's a fine catheter, and each small segment measures pressure, and the patient then drinks water, usually 10 times. And you get a tracing of how good or bad the esophagus contracts. And I have to say, in most esophageal atresia or TOF patients who had surgery and still have an esophagus, they often have very poor motility. They often have what we call an aperistaltic esophagus, where it doesn't actually move much at all, or they have very weak contractions. And that certainly does contribute to acid reflux and the difficulty in managing them surgically as well. 24-hour pH testing. This is often done in conjunction with a manometry in patients with severe reflux disease. To see how bad it is, B, to see how it is linked with their symptoms, and C, to decide whether they're suitable for surgery. And this is where the acid probe is actually placed. It's usually placed about 5 centimeters above the gastroesophageal junction. It's taped to the side of the face. It comes in a little box, and usually some form of notepad to link time and symptoms of when the patient either got chest pain or reflux or any other symptom like cough. And then we can look at the trace in detail and see whether it is has a good symptom probability of it being the symptoms being associated with reflux disease. New thing in our region is we've got access to something called Bravo Capsule, which is a similar way of testing for reflux, but it's got some advantages. One of the advantages is it avoids the sort of catheter being taped to the side of the face. It's actually a radio frequency probe placed in endoscopy in the lower esophagus, and it clips on for 3 days, and then it naturally gets passed in the system. But it transmits the readings of acid over 72 hours, and given extended periods of tracing. And we're finding that of benefit in patients who find it very difficult to wear the probe placed through the nose, or patients who can't have it for various reasons, because they failed a previous normal test, or they prefer to have this because it gives the surgeon or clinician extended snapshot of reflux. And this is about the modern diagnosis of reflux disease. There's various criteria depending on what the endoscopy shows, what the pH testing shows, and whether it's linked in to symptoms or not. So it's a disease that's expanding. There's a lot of research in this area, particularly in sort of standard patients, whether they're suitable for reflux surgery or not. And there's complex algorithms to test whether the symptom recorded at a certain time is associated with heartburn or reflux disease. And there's these two different ways of testing for that. There's the symptom index and the symptom association probability, which is quite postgraduate, and I don't tend to bore you with it, to be honest. A lot of people ask what food and drinks affect the lower esophageal sphincter. And basically it's all the nice things in life, or things like caffeine in sugary drinks or fizzy drinks, in tea and coffee, in sort of Red Bull and other drinks like that can definitely relax the lower esophageal sphincter. Alcohol does it as well, particularly red wine and beers. Relax the lower esophageal sphincter and make patients prone to reflux disease. And sort of westernized diets full of chips, burgers, fast foods, and things like that also affect lower esophageal sphincter pressures and make people prone to reflux disease, either directly in how it affects the stomach whilst being eaten, or indirectly by increasing rates of obesity. And the more abdominal obesity a patient has, the more they're prone to reflux. And that's just a simple sort of pressure effect, really. Smoking, also the tobacco and the nicotine affect the lower esophageal sphincter as well. So in my patients, if they have any of these risk factors, it's the first management protocol really is to manage the lifestyle advice, to lose weight, to try and cut down any of these things, move to caffeine-free tea, reduce the alcohol intake, etc., etc. So yeah, avoid triggers. certain foods are acidic by nature, things like citrus, tomatoes, things like that. Losing weight certainly helps, and a lot of patients will get reflux at night. So another good tip from that is to avoid eating late at night. Eat the evening meal a bit earlier, and just so that there's plenty of time for the stomach to empty. So when the patient goes to bed, the stomach is nice and empty, and that can help with controlling nocturnal reflux symptoms. Just a bit on sleeping positions. Obviously, the stomach is mainly on the right, and the anatomy of it there is shown in this diagram. So it's normally better if a patient has normal anatomy in terms of the stomach and the esophagus in the normal anatomical position. They usually find better reflux control to be positioned on the left-hand side to reduce the amount of acid coming up. Final bit on PPIs. These are proton pump inhibitors. They're probably the most commonest medication prescribed around the world. There's loads of people with indigestion, heartburn, various ailments on these drugs, and they act on the acid pump to reduce gastric acid secretion in the stomach. They're very good at this. There's lots of drugs out there, but the main ones are lansoprazole, omeprazole, esomeprazole, pantoprazole, and rabeprazole. They are all largely the same. They have slightly different dose arrangements. To work effectively, they're best to be taken 30 minutes before eating. And to make them work, you actually have to have a little bit to eat. So you can't take them on a completely empty stomach. What I would say about these drugs is that long-term use over many years, they start to lose their effectiveness. The body gets used to them, and they become less effective with time. And to counteract that, it's often advisable, if that's happening, is to change to a different type of medication to try and regain that effectiveness. Because changing to different type, though they act the same on the same pump, patients can find benefit changing to different variety. Are they safe? This is a common question I get asked all the time. And there's been a lot of research in this area. And what I would say is a lot of the research is very poor quality. The studies have shown a correlation with several factors, including fractures, pneumonia, C. diff, changes in electrolytes, magnesium, B12, chronic kidney disease, even dementia, and even cancer in certain studies. They've not directly shown causation, although some of these features like fractures, particularly in females who are postmenopausal, have good foundational basis. You have to take some of these studies by a pinch of salt. However, it would be important to make sure we give, if possible, short durations of PPIs and then stop them if that is necessary. And if the patient needs to take them on a long-term basis, that they adjust to the lowest dose possible to control their symptoms, unless a doctor tells you otherwise, because there are certain diseases such as Barrett's where it may be best to take a high dose regardless. But yeah, certainly I would, if you have concerns about PPI use, I'd discuss this with your clinician and make sure you adhere to these rules. There are alternatives to PPIs, and these are H2 blockers. They were developed first. Cimetidine was one of the first. It's still available. Ranitidine is no longer available. One of the components in the drug was found to be dangerous, not the drug itself, but the manufacturing methods, and that was withdrawn from the market. But the ones that are available are famotidine and nitazidine, and they appear to be, because they've been around longer, there's more safety data on those drugs. And of course, Gaviscon, Peptac, Rennies, all the sort of stuff can be used to control reflux if appropriate. I think that was the end of the section on reflux. I'm not too sure if there's any other questions from the group that I can answer while we're on reflux before we go to endoscopy.
Yeah, there is a couple of questions. So what I was going to say is before we do, I would suggest we don't stop your slideshow so that we... and just so everybody knows, it's not just me on tonight. We've also got John, who's one of the other trustees, who's also going to be asking some questions. So John, over to you.
Yeah, hopefully you're able to see me all right. Somebody could give me a thumbs up on that. That'll be super.
We can.
Yeah, thank you for that. So yeah, let's just talk about the reflux questions a bit then. Bearing in mind it's entirely possible you've covered off some of these points already, Ewan, but the first one was talking about someone whose son was on omeprazole for 16 years. It stopped working. Tried esomeprazole, but that didn't help much, and he's now on lansoprazole, which is helping a bit. Very similar to something you've just been talking about, actually. What is the difference between these, given that they're part of the same family? Is it an easy way of summarising that?
Yeah, it's just a slightly different chemical formula, but they work the same on the same sort of proton pump. If a certain period of time has elapsed and different drugs have been tried, it may be worth going back on the original one and seeing if that regains effectiveness. But it is a common phenomenon that these drugs do lose their effectiveness with time. And for some people, that's years. Other people, it's many, many years. It's one of these things that you need to discuss with your clinician. What's the best to swap to?
And I guess the slightly comforting news is that you reeled off of at least 5 different types of these PPIs, and one would hope somebody would be able to make some progress by trying them in sequence, should that be entirely necessary.
Yeah, no, indeed. And different GPs, different healthcare settings will have a different preference, usually based on cost. Just be aware of that. That's certainly an issue in our region where the drug budgets need to be reduced, and it's difficulty getting more expensive ones, but that might be the best.
Okay, thank you for that. Now, I think you've substantially answered the next question already, but just let's make sure. Somebody who had a gastric pull-up when they were 2.5 and suffers from silent reflux, especially at night, surgery is going to be difficult, and the question is, what lifestyle modifications can I make? I think you gave us quite a lot, actually, but is there anything else you'd want to add about things which are good or bad?
Yeah, no, I would say that a gastric pull-up operation is a refluxogenic operation. You're taking out the lower esophageal sphincter, you're bringing the stomach up into the chest where it's not meant to be. It's the classical operation that gives you lots and lots of reflux. So yeah, PPIs are usually a must. But all the things I've mentioned before, but the side of sleeping won't make a difference. It's probably best to be upright, one of these V-shaped pillows, raise the foot of the bed, and trade tips with patient groups that have had more experience of gastric pull-ups. Is probably the Esophageal Patients Association and the sort of cancer arena, because they're the more common patients that have had a gastric pull-up, and they've developed tips and tricks to deal with that as well.
Okay, thanks for that. I think you might have said then raise the foot of the bed. Did you mean?
Raise the head of the bed.
Yeah, okay. That's what I would have guessed, but worth checking with you. Thank you. Well, I'll shut up for now, let you talk about your prepared comments on upper GI endoscopy, and then we can whiz through the questions we already had on that subject once you've said a few words.
Yeah, cool.
Thank you.
Upper GI endoscopy, things have changed a lot in sort of 80, 90 years. These are pictures of an old upper GI rigid esophagus scope that I found in our hospital when I was writing a book chapter on the subject. You'll be pleased to see that there are much more technologies moved on phenomenally in the last few years. We've got better optics. They're smaller. They're much more flexible. And in fact, the smallest can actually go transnasally. And that has got some benefits to patients. It's much more comfortable. And it can usually be done unsedated. We just numb the back of the nose and the throat. Particularly if we're just looking, that's great. And obviously, endoscopy is used just for looking, diagnostic. We can also survey things like Barrett's esophagus. And we can also do therapeutic procedures such as dilatation, or even removal of small lesions such as Barrett's lesions or things like that. And this is the range of endoscopes we've got available at the moment. There's big ones for therapeutic procedures. There's side viewing ones to look around corners, particularly duodenum. There's a standard one there, which is a standard gastroscope, and then this is a small transnasal one. But this picture's about 5 years old, so they do have a smaller one, which is about 4 millimeters. So yeah, technology is moving on with endoscopy. This is just a picture of the surgeon dilating a stricture. And strictures are fairly common in patients with tracheoesophageal fistula surgery. Even when it's done as a child, we often inherit them as adults, still needing dilatations. And this is where either the surgical narrowing or the repair site or the connection to the stomach and the esophagus narrows down. And what we do is we use the endoscope, we pass a balloon through and then blow up the balloon to increase the diameter of the esophagus to allow the food to go through. And often, sadly, this needs to be repeated to reduce the rate of dilatation. Sometimes we inject steroid or other drugs to try and reduce the need for dilatations. But often our patients come back time and time again to have these dilatations to try and improve the quality of life and what they can eat. Barrett's esophagus is commonly diagnosed at endoscopy, and I've got some slides on that. And you can think of Barrett's esophagus as really is chronic damage to the esophagus due to reflux disease. It doesn't happen in everyone with reflux disease. It has to be a combination of factors such as genetics, bad reflux, maybe due to more bile than acid. And it's when the lower esophageal mucosa, the inner lining, changes to different type, and it becomes what we describe it as salmon pink. And you can see the sort of pink salmon of the esophageal lining changing. And that whilst that is the severest form of reflux, it's often these patients don't present with reflux. It's often found incidentally because in that cell type changing, they often don't have the standard symptoms of reflux disease, although some do. And overall, it's present in about 1% of the population, but only about 1 in 20 are actually diagnosed. So 19 and 20 will have Barrett's esophagus and not realize it. The main issue here is that the chronic changes can predispose to something called dysplasia, which is a precancerous condition of the esophagus. And if that goes unchecked, it can lead to cancer. And the rate of risk is variable depending what study you read, but it's about 1%. 1% of patients with Barrett's per year will get a cancer. And overall, the risk is about 30 to 125 times higher in patients with Barrett's. So that's why it's very important. We often survey this condition with regular endoscopies, and if there's any sign of dysplasia, there's a treatment to ablate that and remove it with the endoscope. It's called halo ablation, where the gastroenterologist or surgeon will put down a balloon and effectively burn off the dysplastic cells. And I think that's all I've got on Barrett's and endoscopy. So was there any
Well,
questions
might we
on
ask?
that?
Yes, we'll see if we can take a few of the questions about those two subjects if we can. And I suspect, as previously, you'll have already addressed quite a lot of the things the questioners are asking about, which will be super. So talking about the endoscopy questions, first one, when performing an endoscopy on a TOF patient, would you recommend they have a general anaesthetic due to potential swallowing issues?
No, I think it's individual case basis. When so as an adult surgeon, I try and encourage my patients to get their endoscopy done in the endoscopy suite because it's easier to get done. They've got a quick and efficient service. So if we're just looking, that'd be the best way to just do it in the endoscopy suite. Usually with throat spray or sedation. I don't think there's any mandated need for general anesthetic, but I do appreciate that when we have TOF patients who are very young, 16, 17, 18, and they've always had their endoscopies under general anesthetic at the Children's Hospital, it's a very difficult habit to break until they get a bit older. But often we can transition them as an adult to having them done in the standard adult fashion, particularly if there's nothing therapeutic to be done. Some of the complex therapy that can be done endoscopically now is often best done under heavy sedation or even a general anesthetic to allow it to happen safely and effectively. But I'd say individual case selection here, no hard and fast rules.
Thank you. Thank you for that. And the next one is maybe a similar sort of answer. I don't know. How often do you think it would be a good idea to have such an endoscopy for an adult TOF in the case of with some sort of reflux symptoms and perhaps a case without any reflux symptoms?
Yeah, I mean, that's difficult to give precise advice without knowing the details of the patient. But I suspect patients with quite severe reflux disease, even without a TOF, they usually need an endoscopy to exclude Barrett's, to exclude severe reflux esophagitis. So it'd be very important if they've never had an endoscopy to get one done. TOF patients, the rule should remain the same. They should have an endoscopy for severe reflux symptoms, check for Barrett's, check for severe reflux disease. Any sign of difficulty swallowing, dysphagia, vomiting blood, that mandates a fairly urgent endoscopy, to be honest.
Okay, thank you. That's very helpful. We've got a member who's written in saying that his or her endoscopy noted NAD mild infection. What causes that? What treatments are available? And the person notes that when asleep, I feel like I have a golf ball in my throat and my airway blocks off. Doesn't sound much fun at all, does it?
Yeah. It's very difficult to interpret what was meant by that endoscopy report.
Yeah.
Need to see it in detail. The mild infection, I don't know, it could mean anything. It could mean Helicobacter in the stomach. It could mean other things. So I difficult to advise without seeing the exact report.
Okay, I think that's fair enough. We'd certainly understand your difficulty with that. What do you think about the idea that perhaps TOF patients should have biopsies taken for EOE, which I'm not even going to try and pronounce it right, eosinophilic esophagitis, taken at each endoscopy?
Yeah, so I mean, eosinophilic esophagitis is a recent diagnosis. It's only been around for the last sort of 15 years, or certainly come into everybody's arena in that time. It's a very curious condition. It's often associated with asthma or allergies. It may be caused or at least associated with reflux disease. And it causes, I don't have any pictures on the slides, but it shows very characteristic endoscopic features. And I think if there's any doubt if that should be the diagnosis, biopsies need to be taken to diagnose it. And there are treatments for it, including PPIs. There's also steroid treatment called Jorveza for EOE, but it is a very specialist area. I know of no direct relationship to TOF or atresia and EOE, but of course, conditions can be associated with one another. I know of no association. But yeah, if there's any typical endoscopic appearances or there's a concern that it could be the case, the only way to diagnose it is under the microscope with quite extensive biopsies. You have to biopsy the lower esophagus and the upper esophagus, and the pathologist needs to look specifically for what we call eosinophils, which look differently under the microscope. So yeah, that's basically the limit of my knowledge of that condition.
Well, thank you for that anyway. That's very helpful, I'm sure. Lastly, perhaps before we invite you to continue, could we talk about a couple of questions we've got from our members about Barrett's? First one is, what steps can people with GORD take to prevent developing Barrett's? And I think you've given a lot of hints on that one.
Yeah, no, it'd just be the standard advice, really. So do all the lifestyle changes. Certainly, the main things, if you've got Barrett's, are avoiding smoking and alcohol, because these things in combination increase the risk of cancerous change. If Barrett's is diagnosed, make sure your team that are looking after you put you on a surveillance program. The surveillance program will be regular endoscopies, depending on the length of the Barrett's and whether there's any sign of dysplasia. So if there's any sign of dysplasia, that usually needs to be confirmed at a second endoscopy if it's low grade, and then they'd be offered treatment with halo ablation. High grade dysplasia is treated quite aggressively with removal endoscopically and ablation. But yeah, I mean, there was a study in Barrett's patients showing that high dose PPI combined with aspirin reduced the risk of changes of dysplasia and cancer. So that's worth discussing with your clinician. It's called the ASPECT study. And patients were giving twice daily PPI and aspirin, and the combination reduced the risk of malignant change.
Thank you. Just made
the question, or did I go off on a tangent?
No, I thought actually you answered the next question as well very well. There's somebody was asking how important are PPIs in preventing Barrett's in people who have GORD, and there's also a question about what suggestions might you make for your patients who have developed Barrett's esophagus. I suspect you've probably responded pretty well to that.
I think I've covered them. Yeah, PPIs have been shown to reduce cancer transformation in Barrett's. So that's one of the key features, and it's one of the key features that patients might. Some patients think that they don't need to take the medication because it's not improving their symptoms. But if you've got Barrett's, the aim isn't necessarily to improve your symptoms, because a lot of patients with Barrett's don't necessarily have symptoms. It's to reduce the risk of malignancy developing.
Okay, thank you. Well, that's great. Well, perhaps we could invite you to continue with your prepared presentation, and probably pass back to Duncan and allow him to talk through some of the questions thereafter. Thanks.
Okay. Yeah, I mean, quite a lot of your questions were around fundoplication, so I thought I'd cover that next. I think this is the last prepared bit, I think. So, I mean, this is my bread and butter sort of benign operation is laparoscopic anti-reflux surgery. Usually done through 5 cuts in the upper abdomen. We can do it in day case surgery in selected patients, although most of them do end up staying overnight because the operating list in the afternoon, for instance. And they usually have a fairly quick recovery. Most people get back to work in 1 or 2 weeks. There's some dietary adjustments necessary after the operation, and it's generally pretty safe. Risk of conversion to open is less than 2% in a sort of standard patient. What do we do in a standard patient? Well, we fix the hiatus hernia. I don't know if you can see this. This is the muscle of the diaphragm, and this is the stomach, and you can see that there's a big gap, a big weakness. So what we do is we fix the hernia, pull any stomach down, we free up the muscles of the diaphragm, and then we close it with permanent stitches. All the stitches in fundoplication need to be permanent to reduce the risk of recurrence. There's different types of fundoplication. This diagram shows what we call a Nissen fundoplication, where the stomach is a wrapped 360 degrees round the esophagus. And that's a very good reflux operation, but it's not so good for difficulty swallowing or side effects, but it's still a very common operation. Most upper GI surgeons in adults, however, have moved to this partial fundoplication, and this is where the stomach is wrapped partially around the esophagus, around the back, and then stitched at the front. There's some extra stitches to leave a little gap in the middle for the esophagus, and this seems to have some benefit in reducing difficulty swallowing and reducing the side effects of the fundoplication, which include bloatedness and certainly difficulty swallowing. And there's also another type of fundoplication, which is called an anterior wrap, where the stomach is just patched onto the front of the esophagus, and this is said to be 180 degrees anterior, because it's done anterior, where the other one was wrapped around the back, was posterior. And they're the main three types of fundoplication done in adult patients in around the world. What one's best? Well, there's been various studies showing this, and this is a big medical review that reviewed all the data from all the different types of anti-reflux operations, and basically showed that sort of the posterior partial fundoplication was probably the best for reflux control with the Nissen, and the results for that were compared to the other operations. And again, the results in terms of sort of dysphagia and reflux were also better with the partial wraps. So this is what I do in my practice. If a patient has really severe reflux disease, Barrett's esophagus, grade D esophagitis, so I'm often asked to do them in patients who have had a lung transplant to stop them getting pneumonias and infection that affect the lung transplant. I do a full Nissen fundoplication, and if they have slightly lesser reflux, or patient prefers a partial wrap, or they have weak esophageal motility, I'll do one of the partial wraps. And it just depends. Need to discuss that with the patient, see what they prefer. And yeah, it's a sort of balance between controlling reflux and the side effects of the operation. Some of your questions were about post-fundoplication issues. I mean, the first thing to say is the outcome of surgery is usually pretty good, but it's pretty good because we surgeons in this area are usually choosing their patients quite well, and therefore the satisfaction is usually pretty high, but it's not 100%. And the reason it's not 100% is because patients get either difficulty swallowing, or they can develop recurrence of the hernia, or they can develop side effects from the operation, including gas bloat. Some patients can get diarrhea from injury to the vagal nerves, etc. So it's definitely not a perfect operation. And the functional side effects are usually worse in the first sort of 3 months of the operation. So when we do this operation in adults, I'm not particularly talking about tough patients, we give them a special diet sheet to make sure they don't overdo the eating and get food stuck after the surgery. And we give them advice on how to deal with bloatedness after eating, usually avoiding things that are gassy, fermented foods, etc. But usually these functional side effects will resolve with time. And in general, the outcomes of surgery are good, but we can have problems with patients presenting with difficulty swallowing later. And this can affect patients that had the surgery as a child, because the operation can change as the child grows older. For example, difficulty swallowing can happen because the wrap becomes too tight, or there's a technical issue, or a hiatus hernia forms, or the wrap slips. The fundoplication that's wrapped around the stomach can slip into the chest and cause difficulty swallowing. Likewise, things can loosen. The stitches can slowly cut out or sometimes dissolve, even if they're permanent. They're not known to last for absolutely ever. Particularly if patients retch or heave, the stitching can come undone, and the patient can complain of recurrent reflux disease. What do we do when that happens? Well, the patient requires a full workup again, much like I've described before. Sorry, my slides are jumping ahead without me pressing them. And they require careful workup with bariums, the 24-hour pH studies. Maybe we can manage some of the symptoms conservatively with dietary adjustments, working with their dietitians, medication. Others require revisional surgery, which can be very difficult. This is just some endoscopic pictures of what can go wrong. The top one is a normal view of the valve. This is fundoplication at the very top, looking very good, looking like a valve. And it can fail because a hiatus hernia can form and a wide gap appears and the wrap slips up into the chest. That's the middle picture. And the last one is where the wrap was 360, was tight, over the years has come apart. And those patients may be suitable for revisional surgery, where we go back in and revise the procedure to get it back to a near normal wrap if possible. But what I would say about these revisional surgeries, they're very difficult, they're very challenging, they're at higher risk of needing conversion to open surgery, and they really need to be done by surgeons who have a full backup of colleagues and teams that are used to dealing with this operation. And yeah, these are other things that can go wrong over the years. The wrap can twist, although that's usually a technical issue that the wrap was never formed properly in the first place. Or a hernia can develop above the wrap, or a hernia can develop round the side of the esophagus and go up, and that is often associated with difficulty swallowing rather than reflux disease. So these are very difficult scenarios to treat. And I think that's the end of my talk. So I think you had some fundoplication questions.
We do, and a lot of it you've already answered. So again, a bit like what John's done, I'm just going to sort of briefly summarise some of the questions. Because the first one was about, do fundoplications generally need to be redone? Somebody said that their surgeon expects theirs to last about 10 years, and they just wondered if there's any literature to support that. So apart from what you've talked about, which are all the times that it may be redone, is there any other reason? Can it just stay permanent for the rest of their life?
Definitely. Yeah, it can work forever. Yeah, I wouldn't tell any patient they need to have it revised at 10 years. That doesn't make sense to me. They are designed to work forever. Will they work forever? Well, no, they might not. The literature on adults, if it's done for reflux disease, about 20, 30, maybe 40% of patients will end up back on PPIs. But actually, if you test them, only about half of them actually have genuine acid reflux, and they're taking the PPIs for another reason. So the wrap is actually still working. But yeah, they can fail at any point, and the operation can fail within 6 months or a year, or it can last for 60, 70 years. There's operations being done many, many years ago, done open, that are still working. And it just depends on a variety of factors that I've discussed.
Okay. If you can share your screen at some point, Ewan, while we're talking, that'd be great, because then obviously it saves on a blank screen.
Sharing.
The next person's asked, I've heard that valvoplasty is a better alternative to a fundoplication to correct reflux. Is it something you'd recommend, or if for TOFs, is it just a general thing, or would you normally go down the route of a fundo?
Yeah, so valvuloplasty is quite an old term. It's certainly not used in adults anymore. It was last used, there was an operation called a Belsey repair. That was said to be a valvuloplasty, but it's not really done anymore, because that was a transthoracic approach done by a surgeon called Belsey in Bristol, and it was said to be a valvuloplasty, that he was reforming the valve, but it's shrouded in mystery, and the surgeons performing that operation aren't really around anymore, and the standard operation in adults is very much a fundoplication, showing, the pictures I showed you, because that's where the evidence base is, where there's series of thousands and thousands of patients having these operations, rather than, a couple of hundred done by Belsey, where it wasn't actually 100% sure what operation he actually did, and he didn't teach many people to do it.
Okay, that's great, thank you. Next one was, I have esophageal dysmobility, and I've been told that fundoplication could be possible. However, I regurgitate a lot of food that I eat. Is there any other option? And currently this person's taking erythromycin, which is 250 milligrams 3 times a day.
Yeah, difficult to say. Needs a full workup, like I described. pH studies, manometry. Need to see how bad the dysmotility is. And it depends on what surgeon you see, because some have criteria that are different. I've occasionally taken the chance and operated on people with quite severe dysmotility on manometry, but I've assessed them quite carefully with barium, and you can actually see they still have a bit of peristalsis on barium. We get the radiologist to give them a bolus of bread coated in barium, and if that goes down, we can maybe, if everything else aligns, operate on patients with significant dysmotility, but give them a reasonable chance of a good outcome. But it depends on so many factors, and a very careful workup and very careful consenting, because they're very difficult patients to get right.
Okay, thanks for that. So just some general post-surgery questions now. What causes shoulder drop in certain OA TOF repairs, and is it reversible?
Shoulder drop. I mean, I'm assuming the person means the sort of shoulder squinting, the sort of shoulder effects.
I presume so.
We sometimes see that in our thoracotomy patients. Doing a thoracotomy where you cut through the nerves and the muscles to the chest often leads to this unusual thoracic anatomy. So, I mean, sadly, it's usually permanent, but physiotherapy can help. So it's worth seeing a physiotherapist and seeing if they can bulk up some muscles and improve that. But yeah, it's it may work, it may not.
Okay, that's great. How normal is it to get dysplastic cells in adenomas in TOFs? This person, their son's had a recent endoscopy, he's 23, and they say it's unusual at his age. They don't know if it's part of the syndrome or whether it's something to do with past surgery.
Yeah, I mean, it's quite unusual to get that so young. Dysplastic cells do need treatment. So I'd hope he's getting some treatment to remove them. And if there's any Barretts, to ablate the surrounding Barretts. And then make sure, like I said before, that maximum remedies are there to treat the reflux, high dose PPI, all those factors, and even consideration of fundoplication, because that's increasingly what surgeons in adults are asked to do for patients with Barrett's, with bad reflux, who've had dysplasia, who need repeated treatments. it's actually treating the underlying reflux that's important to prevent that progression and make it easier to treat later on endoscopically. So it's a complex area, but yeah, I hope they're under a good team that can offer all that.
Okay, thanks for that. Endoflip. Is this a useful investigation to identify lumen pressure before dilatation?
Yeah, so Endoflip, I haven't personally used it, but it's effectively a means of measuring the pressure, usually of the lower esophageal sphincter. So some surgeons are using it during the operation, particularly to make sure the wrap isn't too tight on fundoplication, or if you do surgery for achalasia, which is a different pathology, making sure you've done a good operation. But I haven't used it. I don't think it has a role in strictures from my reading. But yeah, it's very exciting to use during an operation to make sure you do the best operation possible.
Okay, that's great. And then just the last couple of questions before we end regarding EOE. So we're going to go back to it. I'm not even going to try and say it like John did. So is there a higher incidence of EOE in OA patients, and where, particularly where they may have GORDs?
Yeah, I don't think there's any association. I did see that question before, and I tried to Google, or not Google, but medically Google on PubMed, and I couldn't see anything that said there was an association. But it's certainly a disease that's becoming to the forefront of people's minds medically when we do endoscopy. We're looking for it more. We're probably diagnosing it more, and the pathologists are looking for it more on biopsies. So yeah. Seems to be particularly people with asthma, allergies, eczema. It seems to have a similar sort of profile, sort of allergy type thing that affects the esophagus. So we look at it in people that have this difficulty swallowing, people that have food sticking, which would be a common symptom in patients with TOF anyway. So it may be worth biopsying for if you're having an endoscopy anyway. And there are treatments available for it, so it is worth diagnosing.
Okay, thanks for that. This one will probably be a little bit shorter answer. Does long-term PPI mask EOE?
It's certainly a standard treatment for EOE. Whether it could mask it, I don't know. I don't think so.
Okay. And then final question. I think it's a great question. Don't know whether you can answer it or not, but it's probably more of an opinion than a fact. But one of our members asks, I had surgery done at Birmingham Children's Hospital 51 years ago. And they had a colon graft transplant to the esophagus. And he was apparently under Mr. Keith Roberts. Since then, they've had no surgery, no problems connected to that. And they've spoken to many adults born with this condition. And obviously, some people have had problems, some people haven't. So he's just wondering why it's not used anymore.
Yeah, and I'm glad to hear it done so well. That's amazing. Yeah, I think colon to replace the esophagus is much more complex. It's a very complex operation. Certainly as an adult surgeon, we're doing less and less of it. We're much more familiar with the stomach to be used. And I don't know, I need to speak to my pediatric colleagues, but I think they've changed their technique as well, and I think they're doing it less often, but I don't know why. I think that's probably due to they're less familiar with doing these complex operations. The skill set's moved on, and maybe they're much more comfortable using different techniques, such as the stomach, for example. But yeah, I'm glad to hear he's done so well. That's amazing.
Okay, thank you for that. Right. Thank you, Ewan, for tonight and your presentation. I thought it was absolutely brilliant. Obviously, a few technical itches at the beginning, but don't worry, it happens. It's technology. It's wonderful when it works, and it's never great when it doesn't work as well as you want it to. I have the same issue with at school, so don't worry. So thank you for tonight, and obviously giving up your time to come and talk to everybody. Presentation, as I said, was absolutely fab.